This morning I'm going to present the findings so far from a 4-year study where we've been trying to quantify the burden of disease in Scotland. This is the study team. We all work kind of part-time or few full-time on this study, trying to get the best estimates we can of burden for the first time. So why are we conducting a burden of disease study? We call it SBOD for short, because it's a bit of a mouthful. So the reason that we set off in the first place was, as everyone knows, life expectancy is fairly low in Scotland compared to other comparable countries. It's improving more slowly. And healthy life expectancy, a different metric, which is the amount of times we're living in good health, is also only improving slowly and more slowly than other countries. So the kind of purpose of a burden of disease study is to look at what it is that's causing us to live in ill health. There is a global burden of disease study called GBD. It's a massive study. It's based in Seattle. And they try to estimate burden for every single country in the world. They use modelling to use the data that they can get from different countries, and then using kind of risk factor and other bits of information they know about the country to then try and estimate. And we'd been concerned about the estimates that were coming out for Scotland and what they were using. So we were very keen to look at whether we could use data in Scotland to get a better estimate of what's happening with burden in Scotland, so that we could use it more for planning. So the whole point of it is to make sure that policy making is evidence informed, data informed, and that we can try and drill down to lower level data than you can get from kind of global studies to kind of help with local decision making. So I'm now going to explain, because I imagine most of you are thinking, what on earth is burden of disease? It's something called the DALY, which is a disability adjusted life year. And that is what burden is. It's a kind of mathematical concept. And it's made up of two things. One is the years of life lost due to dying early, and the other is the years lived with disability. And the word disability is what the term we use globally, and it's to denote living in less than ideal health. So for the years of life lost bit of a burden of disease study, that's something that we already know an awful lot about. It's published regularly. ScotPho publish, the GCPH publish information on how many people are dying early. It's based on mortality counts. It's based on how long you would have expected people to live until if they hadn't died early, to give you a number of years lost. And the only difference with a burden disease study is a lot of deaths aren't categorised to a certain death, and in a burden disease study you recategorise everything, so everyone has to die of something specific so you can count. This slide on the left hand side gives you a little example. So we've got a young man. This is a fictionary block of flats with 10 people living in it, and over the course of 2015, 4 of them have had ill health or early death. So we've got a very young man dying, a 20-year-old man suddenly dies. Based on life expectancy in Scotland, we'd have expected him to live till he was 77 years old. And so he lost 57 years of his life. So that's one of the numbers that will go into our burden of disease estimate. We've also got a much older man, and he dies of a stroke. He's 80. The fact he'd already lived to 80 means that we would have expected him to live on average, another 7.8 years. So he lost 7.8 years of his life. So that's quite straightforward to do. The bit that's taken us 4 years is the years lived with disability, and it's all because of this tricky little thing here called morbidity. So it's been really, really hard to try and get the best estimates we can for 132 diseases about what the current situation is of people living with different conditions. So in quite a lot of instances, it's a prevalence estimate, so how many people are alive with that condition that might have been diagnosed with it in the past. For some diseases, it's just you only have it for a short time, so you're counting just how many cases of it. So like flu, for example, how many cases there are of it, and the same with episodes and events. And once you've got an estimate of morbidity, what we then do is say what proportion of people we would expect to have mild, moderate and severe disease in 2015 based on how long they've had it for, how far in the past they got that. And then we apply something called a disability weight. And these severity distributors and disability weights are the ones we use that the global studies use. So we're just using theirs for that. So to measure the burden, here we've got an example of the 45-year-old woman who's got bronchitis. So that really limits her, but for a very short time. So she's actually, in 2015, she only loses a very small bit of her kind of life to disability. And then we've got an old woman, 60, who's got very severe COPD, and that really limits her life. She really struggles to live a kind of full and healthy life. And over the course of a year, the way that the Burden of Disease study works it out is that nearly half, 0.41 of her year has been kind of living in ill health, that she hasn't been able to enjoy to full health. So you add all that together and you've got your burden or your disability adjusted life year. So that's what we've done for lots and lots of diseases. We've used lots of data that we can get hold of, anything we can get hold of in Scotland that tries to tell us what the prevalence or the incidence of diseases are. We've used all the routine data linked together where we can. We've used prescribing data in quite new ways. We've used survey data and kind of registers. So whatever we think is the best source of data, we've used it. Sometimes we've had to go outside of Scotland for things where there just isn't anything in Scotland to tell us what the prevalence might be. The way that burden of disease studies work is it's a disease-based model. It's once you've got the estimates, you can then move on to look at things in different ways, for example, by risk factors. So the first step in the project is to look to get for the 132 defined diseases, and it goes down in levels. I just want to explain this because it's how I'm going to present the results. So level 2 is quite a broad level, and then level 3 are all the diseases underneath that. So for when I present the results, sometimes I'll just be presenting level 2, which is quite a broad category, and sometimes I'll present the results at the lower level. So this is basically the infographic that shows all the results in one slide. So the level 2, which is the broad categories I spoke about, that's these big circles, and then the level 3s around the outside of each one, linking to it. So the first things that really stand out are the big categories where the biggest burden of disease is. Cancer, and mental and substance use disorders really stand out, as does cardiovascular disease and musculoskeletal disorders. So it's when you then drill down into this to look at it that the results become more interesting. So this is 25 diseases at level 3, so that's the lower category, that caused the most burden in Scotland in 2015. The first 5, I don't really like calling it the top 5, but I couldn't think of a better term. It sounds like the top 10. At the very top is ischemic heart disease, followed by neck and lower back pain, depression, chronic obstructive pulmonary disease, and lung cancer. So what we've done is we've broken it into fatal and non-fatal burden. So the fatal burden is the light blue, so that's dying early, and the dark blue is a non-fatal burden. So probably historically you'll have seen graphs like this, but they won't have included the non-fatal burden, and it's really quite stark to see things like depression and neck and lower back pain right up there with diseases like heart disease and lung cancer and the things that you'd expect because they cause so much early death. So those are the five, the five with the highest burden. The next group down take us to 45% of total burden in Scotland, and they start to bring in drug use disorders, some of the old diseases of older age, like the sense organs, so the hearing loss and the loss of eyesight. It also brings in some of the dementias as well. And then this whole list, which is 25 of the 132, covers pretty much 70%, so 2/3 of the total burden in Scotland. And you can see the kind of things that are appearing there and the differences between the fatal and the non-fatal workload. And when I say non-fatal, that doesn't mean how many people. When you look at that, it's not that if you get cancer, then nearly everyone dies of it. What it means is that if you don't die of it, quite often you recover and you'll no longer have a burden. So it's how many people are actually living with the disability associated with that. So you need to look at it in that way when you look at the figures. This slide kind of breaks down the information a bit by age and gender. So you can see, if you look at the bars, you can see that males and females, in terms of disability-adjusted life years or burden, it's fairly similar until you get to the older age group, when there's a lot more burden in the older females. And you can also see from these lines that men have much more fatal burden. So, for example, in the 15 to 34-year-olds, around 30% of burden for men is fatal, compared to only around 10% for females. So females are living with the burden that they get from ill health, whereas men are more likely to be dying early from that. And that's the same at the older age group, and then it kind of comes together in older age. Also, there are differences in what people are living with what the burden is at different age groups. With males, especially in the 15 to 34-year-olds, males more around suicide and self-harm, alcohol dependence, those kind of things, both living with and dying early from the burden of these. Whereas females, it's more around anxiety, depression, and migraine. So these are provisional results. We literally got them hot off the press last week. Probably don't take a picture and post them on Twitter, please, because they're not being heavily checked. So the next step in the study was to produce burden by deprivation. So the 10 levels of socioeconomic deprivation, the SIMD categories for those of you that like the technical detail. So you can see the burden across from the most deprived to the least deprived deciles, split by years of life lost and the years lived with disability. And I've just taken the line across here. So, I mean, a huge difference between the two groups. And at the very least, everything above this line is avoidable, because if the least deprived category can be living with that level of burden in Scotland, these are standardised rates, so then at the very least, everything above that blue line is avoidable, and probably more. So if we go back to the bubble graph, I'm just now going to, because these results are provisional and there's too much data, I'm just going to show you a few of the high-level results for by deprivation. So now I'm just showing the two extremes, the most and the least deprived groups, and I'm showing it for those high-level categories. So here you go. So least deprived group, the burden for mental and substance use disorders, around 2,000 DALYs. We're up to 8,000 DALYs for the most deprived group. You can see kind of really stark differences for quite a lot of conditions, not for others. So for musculoskeletal, for example, the burden is similar across the age group. So this, of course, has implications if you're thinking about workforce, if you're thinking about where you need the workforce, where you need the health workforce. So it's very important to understand where there are very big differences in burden and where maybe they're more similar. Some of these really stand out, which, as you'd expect, chronic liver disease. So just drilling down into those a bit more. I've got two slides now, and they show, this time I've shown the whole trend for a disease. So this is mental and substance use, and I've broken it down by years of life lost and years lived with disability. So the blue line here in the most deprived group is how many people are living with disability in Scotland in 2015 due to mental and substance use disorders, and look at the difference between that and the least deprived group. Even if you take the whole of burden for the least deprived group, it's lower than the number that are dying that have lost life in the most deprived group. So really stark. Cancer, again, a really big gradient. It's mainly due to early death. The living with burden is fairly similar. So to me, that points to either late diagnosis or plus a mix of people getting cancer more. So they die if they've got the cancer, they're dying with it. Cardiovascular disease, again, really stark trends. Not so for neurological. So there's no trend across deprivation groups, either in dying early or living with. These are the next 4 big groupings that I showed you. You can see chronic respiratory disease, a smoking effect there probably, and the liver disease, the alcohol effect. Whereas the musculoskeletal, again, the trends are fairly flat across the groups. So there's loads, and that's just at the level 2. So you can imagine how much data there is and how much we can really look at what's happening and where burden lies with this data. We're all very excited and analysing it frantically at the moment. So what are the implications, policy and planning? So I think the data shows a huge opportunity for preventative public health. I mean, it's got to be preventative with those stark inequalities, and it clearly is preventable. If we could bring, this is what statisticians always like doing, if we could bring down the burden in the most deprived, in all the deprivation groups, that the lowest would have one of the lowest burdens in disease in any developed country. So there's the challenge. Mental health really stands out, especially the burden of living with mental health. And that's got to point to the wider determinants of health if you're going to try and tackle that. Poverty and education, where you live, your income and employment. Still, there's a lot in there, and a bit of the project that's happening at the moment, Elaine Todd in the team is looking at this data by risk factor. So she's saying what amount of burden is due to alcohol, what amount of the burden is due to obesity. And you can by the size of those, there's got to be a focus on things like cost availability and acceptability if you're going to make any difference, I think, to those trends that we're seeing there. There's also self-management and workforce and services proportionate to need, and looking at how that varies by the types of workforce. So I've nearly finished. So what SBOD tells you now, soon in the future. So at the moment, go on the ScotFA website. We've got all the age gender stuff. We've got loads and loads of data if people want to look at the data, or we've got reports, and the reports tell you how robust the data is as well. We have done some work comparing to the global burden estimates, and they are quite different. So that's just a warning if you are using the global estimates. We've got the socioeconomic work that we've just showed you a little flavour of there. That we'll publish that in the next few months, and the risk factor work. The next work we've got planned is to try and project. It's not very straightforward to do that because of all the different data sources, but we're going to try and project forward 10 years so that we can then look at the potential impact of, say, if we could find an intervention that did certain things, and what impact would that likely have on burden in 10 years, because that's quite a powerful message for policymakers, and that's the kind of thing that they're asking for. And we're also, what we can do, but we haven't got any firm plans, is try and look at impact on workforce. We can look at kind of burden of hospital, of secondary care. We can't really look at burden of primary care very well because the data's not that robust, but we might be able to in the future. So what should you do now? Make the case for prevention. look at data-driven, use the data to look at kind of how you're allocating your resources and how you're looking at your workforce, but be careful because burden does not equal workforce. Some conditions that have a lower burden might have a very high workforce implication, so you need to be looking at it with your eyes open on that. And some people are starting to look at the data in that way. Work with us to start to try and use this data to look at the impact of interventions or strategies and the cost, kind of the value for money, cost effectiveness that might go with that. And we've got an email address. You can email us. We're really keen for people to get involved. We're really keen to improve the estimates where we can. So if people have a look and they think we've not done it in the best way, then let us know. Or if you want to get involved in some of the future work, then we're really keen to get more and more people involved in it. So thank you very much.